Welcome to the Expert Edge. This is the show where we bring on experts in their fields of health and wellness practice, and we hear their stories and we learn what they see working in the field of diabetes reversal and prevention. And I'm happy to introduce today's guest, Dr. Raquel Delgado. Welcome.
Thank you very much. Thank you, Lucia. Delighted to be here, delighted to be invited to talk about a topic that is very close to my heart and my clinical practice.
Absolutely. You know, for those of you that haven't met her, Dr. Delgado was born in the Canary Islands, Spain. She developed her passion for medicine at an early age. She was inspired by her own experiences as a child with severe asthma. She has worked at an addiction institute in Iceland, has a food addiction diploma, and with over 20 years of clinical experience, she specializes in weight management and women's health care. For the past 15 years, she's been working on focusing on optimizing care pathways for children and adults that are living with diabetes in the area of London, UK. Her mission is to empower individuals to take control of their health, and we're so happy that you can be with us here today, Dr. Delgado. But tell us a little bit, how did you get started with your interest in this intersection of lifestyle and health?
Before we start, just one correction. I have never worked for the Institute of Food Addiction in Iceland. I did sign up to their amazing training, on the other hand, on food addiction. Just a little correction there.
Got it. Okay.
Okay. So my
I want to make sure I don't say that wrong. So thank you for that correction.
Okay, yeah. So my interest in this area became when I work with a lot of people with diabetes, with type 2 diabetes mainly, but I was also heavily involved up until last year in redesigning, reviewing, and redeveloping diabetes services in my area, which covers a population of nearly 300,000 people. Of those, about 25,000 have got diabetes, adults and children. And I was heavily involved in helping the local health authority to review, improve diabetes services in what we call here health centers, primary care, in community and hospitals. So that's when I started developing a keen interest in diabetes. And also as a family physician, what is called in UK, general practitioner, family doctor, we look after 90% of the people with type 2 diabetes in our health centers. They don't get referred onto hospital services. Or maybe in US it's different, other places they see endocrinologists. In the UK, the great majority of the care is provided in health centers. And I work and I live in an area of Hounslow in London, where there is a very large prevalence of people living with diabetes. So that's how I became very interested. When we started looking and reviewing the services, I became even more interested. Oh my gosh, this is really complex. There is more than it meets the eye. There are so many different types of diabetes. Everybody's experience seems to be very different, which seems to put everybody on the same boat. But the approach has to be more personalized and more individualized because, for example, now we see children and very young adults with type 2 diabetes. And that was very unusual when I started working as a family doctor over 20 years ago. So yes, and then I found that the message given to us healthcare professionals was that once you get diagnosed with type 2 diabetes, you will always have type 2 diabetes, which you always do because it's always kind of there in the background, but you will have to take medication, quite a long list of medications, and eventually the journey will end in taking insulin injections. That is the message that we had through our training as in medical school, and also when I started practicing as a GP. And then I attended a conference given by a family physician who was working with people with type 2 diabetes from Asian origin, and this man was amazing. He was an eye opener because 80% of his patients in the health center were managing their diabetes, type 2 diabetes, with diet, with lifestyle changes. And he's taking a lot of his patients off medication, stop injectable medication as well. And his approach was very holistic, understanding cultural barriers, language barriers, dietetic changes required to be put in place, and giving them a lot of sort of support, mental health support, and so on. So I thought, wow, this is not the message that we've been hearing since I left medical school. And then I started kind of like contacting and connecting with other members of other communities, the low carb community, the keto, the intermittent fasting, and then one thing I think led on to the other, because I started kind of putting into practice the advice given by this forum of healthcare professionals, not just only family doctors, but also nurses, cardiologists, dietitians. And I started seeing amazing results in my patients. So it was quite inspiring. But then I realized that many of my patients, or a good number of them, end up going back to overeat and went back on the carbs, because not all carbs are the same. And they went back on overeating. There was a lot of emotional eating. There was a lot of psychological trauma, and they were using food as a way of dealing with that. So there was a lot of remission, relapse. And I was listening once to a YouTube video from a psychologist in Canada who wrote a book called Food Junkies, 𝗙𝗘𝗦𝗢𝗙, I think her name is, and that led on to my food addiction training.
So interesting.
Yeah, and I read her book. I shared it with a colleague of mine who likewise is working with a lot of people with type 2 diabetes in her health center. And I said to her, I think maybe this could explain why a lot of people can get off these drugs, food that cause them to binge, and there is more to it than we think. This is much more complex than we think it is. I don't think it's just giving people diet advice, sending them away, and hoping for the best.
For sure. I think it's so interesting that you bring out something that is very true, not only in the UK, but here in America, which is that in our standard Western medical training, there's very little attention given to the impact of lifestyle on some of these chronic diseases and the potential for non-pharmaceutical based interventions. And, it was interesting, you were talking about the reversibility of diabetes. And I know that among medical professionals, they're kind of some different preferences around how we even talk about it, in that some people feel like it's kind of blasphemous to say you can reverse diabetes. They're like, oh no, you're once a diabetic, always a diabetic, but you can manage it. But, to me, I find it very interesting when we talk about this terminology, because if someone is 100 pounds overweight, we call them morbidly obese. And if they lose all of the weight and they're at their ideal weight and they're eating a normal diet and maintaining an ideal weight, we don't say they're still morbidly obese. They actually have reversed that because they don't meet the criteria. And when we talk about diabetes, we have very objective criteria for a diabetes diagnosis. And if someone doesn't meet that criteria when they're eating regular food and they're exercising and they're doing all these healthy things, we still want to label them as diabetics. And to me, it's a little bit of a conundrum.
Yes, I agree. And I do have, I look after, so my health center has a population of, in the what we call the diabetes register, so the list of patients with diabetes type 1 and type 2 is is approximately 350, 390 patients now. I do have a good percentage of type 2 patients with diabetes who are now managing their diabetes on lifestyle interventions, and they've been doing so for a good 4, 5, 6 years. Yet we still keep them on the so-called diabetes register because we've been told they still need to get invited for all their annual blood tests, blood pressure, weight, fit. And they keep on saying to me, but when are you going to get me off the register? I don't want to get off the register. I don't want to be labeled as a diabetic anymore. And I say, because we don't know. I mean, this you probably, your diabetes may never come back. However, the jury is still out as to how much longer we need to continue to follow up these patients and continue.
That's really, that's interesting how the system works. And so it's part of your system for following up people that have a history of diabetes. And, and it's interesting because like you say, I think, everyone needs that follow-up. Like every year they should be evaluated, what is their A1C? What are their fasting blood sugars? And whether anybody's had a diagnosis of blood sugar issues before or not, I still think that every year that should be evaluated so that you pick up on it if something changes. So the follow-up is amazing and I think really important. But it's interesting how labels work psychologically, with people. So yes, I hear what you're saying. Now I want us to answer a few questions based on like your experience and your practice with your patients. And sometimes patients that have a diagnosis of prediabetes or diabetes are given what you call dietetic misinformation. And I'd be curious to know, what are the most common pieces of misinformation that you see patients getting, and how does that misinformation impact their long-term blood sugar control?
Okay, so I could talk about this for hours. Because I think we all are different. Okay, we all are different, regardless of whether you have got diabetes or whether you do not have diabetes. And we all have different lifestyles, which are influenced by our culture, our upbringing, what food is available to us, whether we cook or we don't cook, and so on. And I just find that as a standard, all the patients that have diabetes that I see, that they have been given dietetic advice, they all are given a piece of a form, with all the things that they can and they cannot eat, without taking into account all the other variants, because I find that, for example, saying to a patient with diabetes, you can eat anything, it doesn't matter, you can eat anything. It does not have a knock-on effect on your glucose levels, on your sugar levels. Okay, you can eat things like as much pasta as you like, as much rice as you like, as much fizzy drinks, drinks like that. It doesn't really matter if you, for example, stick to 3 meals a day. Okay, but it doesn't matter. These are this is a standard advice. Okay. If you like bananas, you can eat as many bananas as you like, because they are fruit and they are healthy, and you can eat that. And some people might say, okay, the fruit is really healthy, but some fruit are more, in my opinion, for people with diabetes, healthier than others, and it has a less impact on the glucose levels and the fructose levels than others. And you need to snack. Okay, so you have to have your 3 set meals, and you have to snack every couple of hours to make sure that you don't have low glucose levels, without even knowing if that patient is suffering from hypoglycemia, for example, or ever is experiencing any hypoglycemic episodes. And don't worry, you can eat as many carbs and as much glucose as you like, because you can top up your insulin shots. Okay. So no, I think this is wrong. I mean, you can eat as much as you like. Don't worry. If you're on insulin, just make sure that you increase your insulin dose. Um, the same thing with all the hidden sugars and sweeteners in fizzy drinks, for example, or even if they are homemade fruit juices or smoothies, for example. And I sometimes, when patients say to me, well, but you're wrong because I've been told this, I say, okay, buy yourself a glucose monitoring sensor, you know, and have a look, check for yourself what impact those foods are having on your glucose levels. And many times they come back and say, I cannot believe, I now believe what you're saying.
You know, that's one of the things you bring up that I think is so important, is that even people that are pre-diabetic get a lot of education and learning about their bodies if they wear a sensor, even intermittently, because they start to make those connections you just talked about between what they're eating and then what happens to their blood sugar. And I think that's so valuable.
Yeah, and they find it really extreme. I think it's a great educational tool, not only for patients but also for healthcare professionals. You know, just to see, because I get them to use the app. They bring me the 7-day glucose diary, or the 14 days. You can see up to 90 days, and then we can see the graphs. We can see in what food has caused the peaks. We can see how many times they're in range, when they're out of range. And many, I think, empowers people, you know, to make changes as well, because they're so keen to understand more. And when they start using the sensors, many of them are self-funded, because in the very strict criteria as when you can prescribe the sensors in the UK.
Here too. Yeah, same thing here.
But many people are prepared to invest on these sensors for a good month or 2 months until they get it fine-tuned and right for them. So that's one of the things that I always find with dietetic advice. And then
before you go to the next one, one of the things you mentioned was that sometimes people are told it doesn't matter what you eat as long as you cover it with your insulin. Like, just take more insulin if you have a piece of cake for dessert. So what is the big problem for their health if they just keep increasing insulin?
Well, because they're already insulin resistant. So they find themselves that their glucose levels are not going down. So they're not coming down. When they have what called 𝗙𝗘𝗦𝗧, the control has been very poor, because consistently for the 3 months before they have the blood test, the glucose levels has peaked. So it's shown a deterioration. Plus, insulin is a hormone that makes you gain weight. And you're using increasing doses of insulin, but by default, insulin is a hormone that makes you gain weight. The more weight you gain, the more difficult it becomes to control your diabetes as well. Okay. And also the weight gain has a massive impact on your mobility, you know, on your overall well-being as well, you know. So that's one of the problems I find with that advice given, that don't worry, just supplement with insulin. You know, it doesn't make sense to me.
It doesn't to me either. And I'm glad you explained that, because it actually makes their outcomes worse long term.
And because you're trying to ask them, please, you need to control your weight, you need to reduce your weight, but then we are giving them drugs that they are going to make them gain the weight, which is a very contradictory message. And the other thing that really gets to me is elderly people, dietetic advice to elderly people. Don't worry, you are old, it doesn't matter, maybe you go 5 years, 6 years, eat whatever you like. Don't worry, don't hold back on the cakes, don't hold back on the sweet. Okay. However, poor glucose control means the person may already have incontinence problems, and it's just making them pass urine more often, daytime, nighttime. I find that the levels of confusion gets much worse. They become more confused, they become more disorientated. Then they become much more fatigued as well. And then they end up having more urinary infections, which for an elderly person to have a urinary infection might land them in hospital as well, you know? Because they become extremely unwell whenever they pick up a urinary infection. They respond very different to younger people who might just be given antibiotics, hydration, and that's it. But an elderly person with recurrent urinary infections might end up being admitted to hospital because they become very dehydrated and they become very unwell. So this message of, yeah, it's okay, you're in your 70s, you're on 80, eat whatever you like, even if you have got diabetes, is wrong and it's dangerous, in my opinion.
Very, and I'm glad you brought those up. Now, when we're looking at trying to get sugar out of the diet, I know there's a lot of hidden sugars that appear in everyday foods. How do these sugars contribute to cravings and food addiction, and where are these things hiding?
So in my experience, I mean, we have got, I don't know if you have ever come across the sugar infographics, which they were put together by an organization called the Public Health Collaboration in the UK. And
what do you see on those?
Oh my God. So they break down things that we frequently eat in the UK, like porridge oats and a slice of toast, whether it's white bread or whole grain bread, a bowl of rice, so an apple, and so common fruit, common cereals, pasta, and it measures how many teaspoonfuls of sugar there are on all these foods, and it's staggering, the amount of sugar, because a lot of these carbohydrates, which got very low fiber, they have very complex glucose, and they get broken down into sugar by the body. So you have to, okay, if you eat them, fine, but just be aware on how this is going to impact on your glucose levels. And without any doubt, if you got an underlying food addiction, it's just going to stimulate, your reward center, because your reward center in your brain will want to eat more and more and more of it. Hence why, for example, I particularly cannot stop to one biscuit. I have to have the whole packet.
Yeah, and biscuits, what you call biscuits, we usually call cookies. But
cookies,
yes. Yes.
Who can eat just a quarter of a cookie?
Right.
I can't. I have to eat the whole cookie or 2 or 3 cookies if they are available. And the same thing like with things like Nutella, or like sort of they're so nice. And you put a spoonful in your mouth and you want another and another and another. And that is stimulating the reward system, the brain reward system. Hence why one has to be fully aware of where all these hidden sugars are there, that they're going to cause a trigger. Yeah. And I think that's why it's so important, if there is an underlying food addiction, that it gets diagnosed. Although I know it's not recognized as such, food addiction still has a long way to go to be recognized by the medical establishment and by the WHO. But I know there are a lot of people in the background working on that.
Yes, there are. And I know, like, some years ago, Harvard put together actually a quiz that people could take to measure whether they were addicted to food or not. And it's been validated. But like you say, there's not a general acceptance of a definition for such things. But it's very obvious that it exists, and that people really suffer from these things because certain triggers will push them into eating a lot of these processed foods. And like you say, they have a chemical reaction in the brain that makes you want more and makes it hard to say no. And understanding that, I think, is important if we want to really deal with that. We have to start by becoming aware of what is happening. And I love how you talked about these hidden sugars, because here in the United States, for example, we have sugar listed as an ingredient in food under at least 60 different names. And so you may be just looking for sugar, white sugar, brown sugar, molasses, or something where there's all these other names that we don't use for sugar in our kitchens, but are sugar in our bodies nonetheless. And so becoming more aware of how these sugars are hidden under different names can be really helpful. And I love that you're going to have a little handout to share with our listeners that gives them some tools along these lines and helps them figure out what are some of these tips I can do for getting these things out of my life and losing weight, controlling my blood sugar better. But before we go to that, there's another thing that I think is really important for many of our listeners who might be women in their middle ages. And I'd like to hear from you how estrogen dropping during perimenopause and menopause, how does that affect insulin sensitivity and a woman's risk of developing type 2 diabetes?
So that's something I found that I don't have prediabetes, I don't have diabetes, but I gained weight when I started going through the change. Like a lot of women, we put weight on, and by the end of once you reach your menopause, you may have gained anything between 10 to 15 kilograms. Sorry, I don't know how that translates into the imperial. 1 stone and 2 stones.
That's somewhere from 12 to 25 pounds.
So then I was finding that women who, because of being a woman myself, being a doctor, I get to seeing a lot of women, and then I took up some training on menopause, because I was seeing more and more women with all the long list of menopausal symptoms, and I went through the menopause myself. And I thought, well, I need more training on this, because before that happened to me, I dismiss it. Sure, it's not that bad. Can't be that bad. I'm sure they are just overplaying their symptoms, until it was my turn. And then I started seeing women who have got pre-diabetes, who are going through the change, and then suddenly they became diabetic. Or women who have got diabetes, but they were trying their best to manage their diabetes with lifestyle changes. And then I saw their HbA1c creeping up, plus their lipids, their bad cholesterol going up as well. And I thought there must be some connection here, because this is not just a coincidence. And then I went to a menopause conference, and I was with a colleague who is also very interested in menopause. And there we sat there in one of the lectures, and they mentioned that the estrogen deficiency causes the body to become more resistant to insulin. And I thought, bingo. And it's something that they're going to start looking more into it, particularly in the management of women who have got diabetes. Because a lot of the women, when they go through the perimenopause and the menopause, we start gaining fat around the abdomen.
Right.
And that is the visceral fat. That's the fat that is going to put you at risk of having insulin resistance, and is going to put you at risk of developing diabetes. And a lot of the women say, I got this bulging belly, all my fat in my perimenopause and menopause is building up in the abdomen. And I was thinking, that's really interesting, because the body is running out of estrogen. So it's building up I didn't make that one up. I had it as a conference as well. So the body's building up all this fat around the abdomen to try to get some estrogen from there as well, okay, from the fat. And that extra fat also is a cause of insulin resistance and weight gain. And as we all know, weight gain can put you at risk of type 2 diabetes. So that's where all the connections started coming from. And now I am able to give a more comprehensive consultation with women who come in with menopausal changes plus or type 2 diabetes control. And I always start talking about how we're going to start looking into these things and how we're going to start managing that. Because obviously the weight, maintaining a healthy weight is of much importance, because you don't want to end up having type 2 diabetes after your menopause is over. So very interesting topics.
It is. And I wish we could dive into it more, but we're about to run out of time here.
Yes.
And I do want you to share one of your favorite tools for breaking addictions. Whatever, one thing that's practical, somebody can walk away with and say, oh, here's something I can do that can help me to break a sugar addiction or a food addiction.
I think the biggie for me is people recognizing, having insight into how their behavior around certain type of food, okay? Because it's like alcohol addiction, it's like any addiction. You have to have the insight. You can no longer be in denial. You have to accept that you have a problem with this. Okay, because in order, if you don't accept that, then it's very, very difficult to ask for help or to seek help. So if you find yourself totally losing control over certain food, and it's a recurring episode, it's not just a one-off. This is something that keeps on happening, and people are telling you, because a lot of the times we just don't want to hear it, we don't want to know about that. Then it's time to start thinking, okay, I think I got a problem here, and I need to, and that's the beginning. That's the beginning of seeking help and changing, in my opinion. So that's the one thing, that be more open-minded and be prepared to listen to what other people are saying around your addiction, and recognizing it yourself. A lot of people are embarrassed to talk about addiction because they see that as a loss of control. And what I want to say to people is, it's not you losing control, it's your mind deciding, is making those decisions, the brain reward system, making those decisions on your behalf.
Yes, I think that's really good advice, because until we start paying attention to, like, how are we thinking around these things? What is triggering some of these behaviors, it is very difficult to make changes. But becoming aware is such an important first step. I love that. So for those of you that are listening, don't forget to check for the link that's in the description right below wherever you're watching this video, and you will have access to a free gift that Dr. Delgado has put together just to help you. It's going to give you some tips on how to manage your weight better, and you will want to go check that out. So just check for that link below and grab that. And I just want to say thank you so much, Dr. Delgado, for being with us here today. I've really enjoyed this. And I want all of you listening to remember that health is wealth, and it comes by choice, not by chance. So thank you for joining us today.
Thank you very much, Lucia. Nice talking with you. Take care.